80% of a hospital's data lives in unstructured clinical notes, physician dictations, nurse observations, discharge summaries, all in dense prose, full of abbreviations, misspellings, negations, and hedging. And under HIPAA, full of identifying information you cannot legally hand to a model. Doing NLP in medicine is not doing NLP with a scary background image. It's a specific set of problems that don't exist anywhere else in the field. Welcome to Video 9 of Lecture 9, NLP in Medicine. Clinical Notes, De-identification, Clinical NER, the hard case where language processing meets life and death decisions, and a legal framework that says you may not carelessly show this text to a model. Different rules, different failure modes, different everything. Video 8 closed with a warning. Medical simplification is dangerous because meaning has to be exactly preserved. Today we go one level deeper. What does clinical NLP actually look like? The workflow, the datasets, the specific ways language behaves inside a hospital that break every model trained on Wikipedia. Today's puzzle: why does a system that reads Wikipedia perfectly fail on a discharge summary? Medical language uses different vocabulary, different syntax, heavy negation, extensive hedging. Time is critical, and it's usually implicit. And half the important nouns are abbreviations that resolve differently depending on the ward. This is not Wikipedia. Today's 3 beats. First, the datasets. ITWAB2 shared tasks, Uzuner 2011, and Mimic, a de-identified ICU corpus that unlocked most clinical NLP research. Second, de-identification. Removing PHI before you can share or process a note. HIPAA's Safe Harbor List. Why this is a specific hard NER task. Third, clinical NER. Extracting drugs, symptoms, tests, and anatomy from notes, and the specific way medical language breaks generic NER models. Beat 1. The datasets. Clinical NLP has an obvious problem. Hospital notes are protected. You can't just scrape them. So the field runs on a small number of hard-won shared datasets. Uzuner and colleagues at MIT and Harvard ran the ITWAB2 shared tasks from 2006 through the 2010s. De-identification, smoking status, medications, relations between problems, tests, and treatments. Each task released a labeled corpus that trained a decade of research. The other big one is Mimic, Medical Information Mart for Intensive Care. Johnson and colleagues 2016, 60,000 ICU stays from a Boston hospital, de-identified and released to researchers under a data use agreement. Notes, labs, medications, vital signs, mortality outcomes. If you've heard of any clinical NLP result in the last decade, it was probably trained on Mimic, which also means every model has the same blind spots. One hospital, one country, one demographic. One layer under the datasets, the vocabulary. UMLS, Unified Medical Language System, a hand-curated database from the National Library of Medicine that maps every medical concept to a stable ID, myocardial infarction, heart attack, MI, AMI, all mapped to the same UMLS concept. UMLS is the medical Wikipedia and the medical WordNet in one. Every serious clinical NLP system uses it as a normalization backbone. Beat 2. De-identification. Before a hospital can hand a note to a researcher or an outside model, you have to remove protected health information. HIPAA lists 18 categories: names, dates, addresses, phone numbers, medical record numbers, even zip codes if they'd allow re-identification. This isn't a nice to have, it's a federal law with real penalties. De-identification is basically NER. Find every PHI token in a note and mask it. Stubbs and Uzuner's 2015 ITWAB2 de-identification task released a dataset with every PHI span labeled. Modern approaches use BERT family models fine-tuned on that data. Precision and recall both matter, but recall matters more. A missed PHI is a HIPAA violation, while a false positive is just a redacted date. The subtler problem: de-identification can degrade downstream NLP. If you replace every date with a token, a model trying to compute the interval between admission and discharge loses information. So the field has moved towards surrogate replacement. Instead of masking, substitute a random but plausible date, name, or address. Preserves structure. Removes PHI. Standard practice in modern DID pipelines. Beat 3. Clinical NER. Once you've de-identified the notes, the real work begins. Extract every medical entity, drugs, doses, symptoms, diseases, tests, anatomical locations. The ITWAB2 2010 Concepts task and its successors established the label taxonomy that most modern systems use. And then Alsensor's 2019 ClinicalBERT. BERT, fine-tuned on mimic notes, became the go-to backbone. Where clinical NER breaks that generic NER doesn't. Negation, denies chest pain, has to not tag chest pain as a positive symptom. Hedging, possible pneumonia means the doctor isn't sure, and the downstream model needs to know that. Family history, father with MI, has to not tag MI on the patient. Modern systems tag entities plus assertion status, present, absent, possible, in family, historical. Where all this goes: clinical decision support, pharmacovigilance, mining discharge summaries for adverse drug events, cohort discovery for clinical trials. And now, LLM-assisted physician documentation. Draft the note, the physician verifies. Every big EMR vendor is racing to ship this, and the failure mode is exactly what you'd expect. A fluent-sounding wrong assertion in a medical record, which is why every one of these systems ships with a physician-in-the-loop requirement. 3 takeaways before the quiz. 1. Clinical NLP runs on ITWAB2 shared tasks. Uzuner 2011 and MIMICII. Johnson 2016. And on UMLS for concept normalization. Small hard-won datasets with narrow demographic coverage that biases everything downstream. 2. Deidentification is HIPAA-mandated NER, over 18 PHI categories. Recall matters more than precision. Modern DID uses BERT family models with surrogate replacement, so downstream tasks don't lose information. 3. Clinical NER extracts drugs, doses, symptoms, problems, plus assertion status present, absent, possible, family, historical. ClinicalBERT is the go-to backbone, and every production system has a physician in the loop. Quiz 1. Why is MIMICI? Johnson et al. 2016 both the default clinical NLP dataset and a source of bias in the field. A mimic was released without de-identification. B-mimic contains 60,000 ICU stays from a single Boston hospital. So models trained on it inherit that demographic and institutional slant even though most clinical research uses it. C-mimic only contains lab values, no clinical notes. Or D-mimic is a synthetic dataset with no real patients. B. Mimic is one hospital, one country, one demographic, one care setting. Every clinical NLP result you've heard of was probably trained on mimic, which is a huge win for reproducibility and a real problem for generalization to other populations and hospital systems. Quiz 2. For date identification of clinical notes, why does recall usually matter more than precision? A precision is impossible to measure in clinical text. B. A missed piece of protected health information, PHI, is a HIPAA violation with legal penalties, while an over-redaction is just a lost date or name. So systems are tuned to catch every PHI even at the cost of extra false positives. C-recall is only used for image models, or DHIPAA only cares about precision, not recall. B. The cost is asymmetric. A missed PHI is a legal problem. An over-redaction is inconvenient. Modern de-identification pipelines therefore tune for very high recall and accept some false positives, then use surrogate replacement to preserve downstream utility. Quiz 3. In clinical NER, why is it not enough to just tag an entity like myocardial infarction? A clinical notes use only pictures, not text. B. The same entity mentioned can have completely different clinical meaning depending on assertion status. Denies MI absent, possible MI uncertain, father with MI family history, SPMI 2010 Historical, so systems tag entity plus assertion status. C. LLMs cannot tag medical entities. Or DMI is a HIPAA-protected identifier. B. Assertion status is the difference between "this patient is having a heart attack" and "this patient's father had a heart attack 20 years ago." Modern clinical NER produces entity plus present absent possible family historical labels. Missing that distinction is a downstream disaster. Back to the puzzle. Why does Wikipedia-trained NLP fail on clinical text? Different vocabulary, different syntax. Assertion status changes everything, and the whole domain runs under legal constraints no other application faces. 9 applications down, 1 to go. Next up, the closer. Everything L9E9 said in one sitting, and a hard pivot into Lecture 10. Bias, hallucination, alignment, the endgame. Next time, the closer. Everything Lecture 9 said. 10 applications in a single arc. And a hard pivot into Lecture 10. The frontier, bias, alignment, the course wrap. Hit subscribe.